Hello, everyone. Welcome to today's webinar. I am Sharia Ali, and I am the SLP Practice Advisor at ACSLPA. And as part of my role, I oversee the college's equity, diversity, and inclusion initiatives. So I'm excited today to be here today providing an overview of the college's latest guideline, which is titled Anti-Racist Service Provision for SLPs and Audiologists. Now, this webinar is going to be a little different than the typical webinars that we have that introduce new college guidelines, in that it's sort of a part two from the first webinar on anti-racism that was presented in November of last year, I think. And because we'll really also be spending some time today really explaining and expanding on the background information and the concepts within the guideline. So as usual, I'll go through a bit of housekeeping first. You'll notice your camera and your mics are off, but the chat is available for you for the duration of the webinar. Mackenzie, who keeps our webinars running smoothly, is available if you have any technical issues at any time. If the chat isn't available to you, you can contact them at the phone or the email shown, and they can help you out. We'll have some time for questions at the end, so if the chat's looking busy, save your questions to the end so they don't get lost. And this presentation will be recorded and will be available on ACSLPA's YouTube channel in about a week. So we'll get underway. Just noticing it's a smaller group than we usually have, so a bit more cozy, so it kind of fits with the rainy and great weather that we are having in Edmonton right now. So we are gathered around what we call Alberta, what is the traditional and ancestral territory of many peoples: the Blackfoot Confederacy, the Cree, Dene, Saulteaux, Nakota Sioux, Stoney Nakoda, and the Tsuut'ina Nation, and the Métis people of Alberta. So we acknowledge the many First Nations, Métis and Inuit, who have lived on and cared for these lands for generations, and who will continue to care for these lands for generations to come. So most of us will be familiar with land acknowledgements, hopefully, and maps like the one shown, which remind us the truth of wherever we go in the world, we are on Indigenous land. But I just want to add a reflection on this quote up here. To acknowledge truth is to acknowledge that truth is at the forefront of the conversation. Because too often, we see people and organizations that jump to reconciliation efforts without really sitting with the truth. But without the truth, there's nothing to reconcile. So we really need to look at it and hold space for it. So I invite you, as we go through the slides and as you think about anti-racism and your profession, to really keep the hard truth of Canada, historical and current, at the forefront. So I thought it would also be helpful to share some of my truth and how it got me exactly the hair presenting to you on this topic. So I'm a racialized SLP. I'm a first-generation immigrant to Canada and a speaker of a dialect of English. So when we talk about some of the barriers to culturally safe care, how they impact clients, and how to mitigate them, just know that I've lived some of that in accessing healthcare in general and in watching clients like me access SLP services. So that lived experience, along with my clinical experience, has led to what's now a very special interest in anti-oppression and SLP. And that's why I'm here talking about this topic to you today. So like I said, our agenda is going to look a little bit different from the usual webinars on ACSLPA guidelines. So we're going to spend some more time on the background on why these guidelines were developed in the first place. And then we'll look at ways to engender anti-racist practices in your one-to-one interactions with clients. But there are some caveats. First, this is a starting point. You should also know that this work is very self-focused and it's less clinical and prescribed. And also, it might challenge some very entrenched knowledge and knowledge systems. So we'll put all of that together in a case discussion, and then we'll wrap up with question period at the end. So when we were developing the guideline, we looked at the literature, of course, but particularly the literature that incorporated the perspectives of racialized or culturally and linguistically diverse clients and patients. And we saw, of course, there's hard evidence that systemic inequity exists for these groups, but also we saw that there are some major factors that need to be considered when we're examining inequity. And that's a biomedical model, a biomedical orientation of the professions, disparities in social determinants of health, and power imbalances that are inherent not only in society, but that are also built into therapeutic interactions. And because many of us may not have had opportunities to closely examine these concepts and how they apply to our practice, we'll begin by looking at each of them in turn. Right. So historically, the biomedical model has formed the basis of healthcare education and delivery, including in our professions. So the biomedical framework really focuses on the individual and individual pathophysiology. And because of its focus on the individual, many of us will have been trained to view the client or their hearing or communication disorder in isolation from other critical contexts, critical considerations in their context. So think, for example, of a new immigrant family with a 3-year-old child who has a hearing loss, who's prescribed hearing aids, but who doesn't want to wear them because they're 3. In the biomedical model, the solution to the issue in your viewfinder, which is hearing loss, would be to make sure the child is wearing their hearing aid at home. However, if we only zeroed in on that problem and that one piece of the puzzle, we might be ignoring relevant information that could be critical in improving the client's prognosis and outcomes. So we would be ignoring things like the family's pre-migration history, their views of disability, the healthcare systems that they're used to, how well they're adjusting to the new healthcare systems they're in, their views and comfort with technology and other culturally bound factors. And if we ignore these, we would miss opportunities to truly integrate their lived realities into their care. So that's why it's critical that we begin to really ground ourselves in a framework that recognizes the connection between the biological, psychological, and social functioning of an individual, one that really acknowledges the impact of sociocultural factors, and one that recognizes that the client is the one that holds the expertise on their reality. And that's a biopsychosocial model. So when we have these additional layers to the context of the client, we'll find that different avenues and approaches open up. However, there are some considerations with taking this approach. First, when we're trying to find out more about the context of the client, we need to understand that there will always be questions about the client's context that only they can answer. And clients are not going to share their answers if they don't have a relationship with their provider or if they feel like what they say will be judged. So it's important when we use a biopsychosocial framework or model that we are mindful of how we act on and how we use the information we gather about the client's context. So using the biopsychosocial framework also requires that as health professionals that we are mindful of the power differential in the therapeutic relationship. So although it might not feel like it because we're all under-resourced and we all advocate until the cows come home for our clients and nothing changes, we need to understand that as SLPs and audiologists, we do have a significant amount of power in our relationships with our clients. And that is to say, we have a significant amount of power over our clients. In many cases, we have a not insignificant amount of say in their involvement with systems like healthcare and education. Sometimes they have to let us into their homes if they want services, and that's huge. We make decisions over who gets services, what services look like, who gets discharged, and for what reasons. And in some cases, we get a say in the judgments made of caregivers of children involved with children's services. So while we might not think it's a lot, think of what that must feel like from the client's perspective. So assessment and intervention can feel routine to us because we do it day in, day out. But to our clients, they can be significant life events. And it's important to understand that racialized clients are in an additional power under position due to the subtle and many times unconscious effects of systemic oppression and because of the dominant and subordinate culture dichotomy in society. So the power differential they face as clients is compounded by systemic discrimination and racism. Some of the main points I hope you take away from today is an acknowledgement of the power that you do have, which is significant by virtue of your profession, and that the differential between clients and yourself is heightened for racialized clients. And we'll talk more about this later, but one of the major requirements for anti-racism in practice and that shift towards equity is power transfer from the agents with more power, that's us as the providers, to the agents with least power, and that's our marginalized clients. So it's also important when we talk about racism in healthcare and in education as well, that we talk about institutional and structural racism acting as determinants of health for many population groups. So that is, racism is part of the complex circumstances into which people are born and live, and it impacts their health and well-being. So institutional, structural, systemic racism result in policies, procedures, and just norms that impact many, many aspects of life for certain groups of people across their lifespan. So some are shown here, like unemployment, working conditions, housing, etc. The point's not for you to memorize all of these various social determinants of health, but to gain an understanding that an individual's health and well-being are influenced by factors that are external to them, and that oftentimes these factors are completely outside of their control. So you might be asking, what do determinants of health have to do with SLP and audiology? Like, we can't improve anyone's housing, we can't go fix infrastructure, etc. But I hope that you see that there's a clear line from social determinants of health to our work. These social determinants of health, they all impact health and health behaviors. And as hearing and communication health professionals, we may only be treating a sign or one symptom of these determinants of health, but using the biopsychosocial model and being aware of the client's wider context does require that we think about the social determinants of health. And we use that awareness to help guide our understanding of the client and the decisions we make about their care. So for example, we wouldn't assign food play as a home activity for a family who faces food insecurity at home, or a client that's asking a caregiver to come in for weekly therapy might have to consider what that might mean for the family if there's a lack of bus service in their neighborhood, and that means that coming into therapy turns into an hours-long round trip. Unfortunately, the academic and gray literature in our professions has slowly been increasing its focus on inequity in the services we provide as SLPs and audiologists. And the literature shows that systemic inequity in our services happens across the lifespan of services. So it starts with access, it moves through the different experiences different people have with our professions, and it ends with disparate outcomes. So when we talk about access and barriers for culturally and linguistically diverse clients and patients, first, there are some real and significant barriers to access to caring and communication health services. So underutilization of services happens when there's a lack of awareness or perceived irrelevance of services within marginalized communities. And it's important to understand this can happen very insidiously, like when potential clients can't see themselves represented in the public-facing staff of a clinic or in the marketing and advertising materials of an organization, or if it's not explicitly communicated that services can be provided to individuals who don't speak English. Also, when individuals who make referral decisions use dominant culture norms to make these decisions, under-referral to appropriate services can and does occur when real disorders are classed as differences. And we also have to acknowledge that there is a real and justified lack of trust and or fear of public institutions, particularly the ones we work in, which health and education, and that causes underutilization of services. It's also critical that we acknowledge the very high potential for cultural harm in the work that we do with clients. So we're all operating in systems where systemic oppression is built in. And for most of us, particularly millennials or older, our training and education to do the work we do is heavily, heavily steeped in dominant cultural norms. And how heavily entrenched these are, it can't be overstated. So I'll give you a personal example. Where I'm from, the expectations of independence in children are very, very different. So children aren't expected to be independent with daily life activities at the same sort of younger age as expected in Canada. So I would see my children in my family being fed or dressed by an adult at like 4 and 5 and 6 years old. And having been taught these Eurocentric standards of child rearing, I would make internal judgments about the caregivers, or sometimes I would explicitly say, they really should be doing that by themselves by now. And that was culturally harmful of me because I was a child development expert, judging people on what really is a cultural standard that's not applicable to them. So I just share that story to show how our models and frameworks for education and service delivery so strongly promote dominant culture norms, that even a clinician who does not identify with dominant culture couldn't see past them. And also, as long as there's a lack of diversity in the experiential knowledge in our workforces, our collective knowledge on the norms of how we interact with clients, the expectations we have in these interactions, and how we deal with differences will not be as culturally sensitive and responsive as they need to be. And so all of these factors lead to an increased potential for cultural harm in our interactions with clients. So when we look specifically at issues in assessment and treatment, we see that to this day, over-referral of racialized or culturally and linguistically diverse clients is still happening. And that's due to difficulties differentiating differences from disorders. And that's because dominant culture norms are used as a referent or the standard. And you might also recall that I spoke about under-referral a few slides back. And the fact that both under and over referral are happening really speaks to the difficulties of assessing without appropriate assessment tools. So this can be the lack of assessments in other languages, but it can also mean the lack of developmental norms in the literature when we go looking for them, lack of time and human resources like an interpreter to complete naturalistic assessments. And we come up against the same issue with intervention tools. It's important to realize that many intervention practices are actually based on dominant culture norms. For example, parent training on stimulating and promoting language development in the home. And in these cases, when we don't take a critical eye and really work with clients to incorporate their culture, what we really might be doing is promoting just assimilation to the dominant culture. Also, we have to consider that when the evidence base excludes culturally and linguistically diverse clients in their samples, we've all seen the sample descriptions as monolingual English speakers, the result is actually best practice approaches that may be inappropriate to anyone outside of the dominant culture. So when we think about everything we're up against when providing safe and equitable care to racialized or culturally or linguistically diverse clients, cultural humility should enter the conversation. So at the core of cultural humility is a real focus on the self. It's a lifelong approach to self-reflection and self-awareness building of one's own assumptions, beliefs, and biases. So we all have unconscious biases, and this includes a tendency to assign positive stereotypes to certain groups and less positive attributes to other groups. And cultural humility really requires a provider to acknowledge that they have their own way of doing things based on their background and experiences, that other people have different ways of doing things. Cultural humility requires us to reflect on how much of our own perspectives we may be placing on a client and our expectations of how they should think and how they should act. So for example, one of the situations where cultural humility can be applied is in that view of the role of the clinician in therapy. So our training and our framework in Canada and Alberta really heavily promotes caregiver involvement in decision making and in implementation of therapy. However, this level of responsibility may be totally foreign to people from other cultures. And if the clinician doesn't recognize that this expectation of their role is culturally bound, they may make judgments on clients who are not accustomed to that level of responsibility, to being involved in the decision-making and implementation of therapy. They might make judgments like clients not engaged, or they're not motivated, or even non-compliant. Files can get closed and services can even get discontinued when this happens. So it's important to be mindful of how much of our expectations of clients is grounded in our own perspectives and frameworks for understanding the world. Now, the power differential that we spoke about earlier is also front and center when practicing cultural humility. In this framework, the power dynamic between yourself and your client is a mandatory consideration when we're thinking about how we view our client. So it's as important to consider, I think, as the family history or the treatment history. And practicing cultural humility also requires us to transfer some of that power from the agent with the most power, so that's us, the providers, and the systems that we work in, to those with the least power, and that's our clients. And we can do that. We can transfer some of that power by recognizing that clients have significant expertise in the relationship. They hold significant expertise on themselves and their context. And we also address the power differential when there's respectful collaboration and bidirectional learning in a therapeutic relationship. So we should avoid approaching relationships with the expert perspective. Acknowledge that there's important information that impacts care that only the client can provide. We should seek that knowledge respectfully. Ask outright how it can be incorporated into care. So when we're open-minded and curious, we can provide care that is sensitive and responsive, even if we didn't have any information starting out about the client's background or their culture. So one way to start that self-reflection that's needed for cultural humility is to engage in situated practice. So this helps us understand where we are and what factors are influencing how we see the world and how we behave. So let's look at the chart shown, which shows some, but not all of the aspects of self-identity, like ethnocultural background or skin color, language, gender identity, age, etc., etc. So what I'll ask you to do now is think about yourself and your life and all of these factors, all of these identities. Which identities do you think about most often? Which identities do you not have to think about very often at all? Which ones do you feel more keenly in different settings? Are there any that you feel put you at a disadvantage in society? Or are there any ones that you feel give you some advantage in society? Now, your social location is going to be different from the person sitting next to you. It's definitely probably going to be different from your clients. So it's important that you understand where you are, but also that you know that your client is probably going to be coming from a completely different place. They won't know what you know, and they won't have the same perspective as you. So it's important that at the very least, we strengthen our understanding of our own perspectives, and we know that these perspectives come from our own very specific social location or identity. Now, this is just sort of a little cheat sheet of sorts on cultural humility. So first, practicing cultural humility requires that you practice humility in the assumptions you make about knowing the world from the client's perspective. You won't know it. Think about all the facets of social identity and how yours may differ from your clients. Recognize, this is huge, recognize the potential to place some of the expectations and norms of your social location on the client. And in order to address that, you should learn about the client's perspective, importantly, from the client. And do this respectfully, even when what you learn is different from what you know. So we should also discuss cultural safety. And cultural safety, again, keeps the power differential at the forefront, and it seeks to balance out power differentials by providing care within the client's norms and values. So again, it's grounded in the knowledge that different people have different ways of seeing things and doing things. And cultural safety, really importantly, it lets the client decide what is safe or what safe means to them from their perspective. So culturally safe care is free of discrimination or racism. So of course, we as clinicians, we can't know if the care that we provided was safe. Only the client who experiences it can know that. So again, this requires us to build relationship, really work with clients, and get to understand their whole perspective in order to provide safe care. Jessica Ball at the University of Victoria has some really excellent resources on cultural safety and SLP, some of which are referenced in the reference slide at the end of this presentation. So when thinking about cultural safety, think about these 4 Ps. So first, what protocols do you need to be aware of that might impact the therapeutic relationship? So this can be something as simple as how to greet and refer to your clients, or it could be what expectations, understanding what expectations a client has that a relationship needs to be built before sharing personal information or working with you. Think about what tools or resources you might need to ensure culturally appropriate care. And it's really important to note with protocols that your client or someone familiar with your client's background is probably going to be the best source of information on protocols. Don't assume that you know. Even clinicians are not immune to filling in gaps that they might have about the client with stereotypical information from other clients, the media, or other sources. And as with cultural humility, being aware of your own beliefs is key. So again, that's just acknowledging that different people have different ways of doing things. So things like views of disability or parenting or just how everyday life activities are completed, those things are different just from the way that you do it. They might not actually need to be remedied. So we need to be really mindful of differences in views between ourselves and our clients. And we again see that partnerships are critical, not just with the client and decision makers that they assign as important to them and their care, but also with cultural brokers or facilitators as needed and appropriate. So recognize that although you hold clinical expertise, you might need help from someone with expertise on the client and their background and on providing culturally responsive care. So the end goal of cultural safety is always that positive and safe cultural options exist for the client. So remember, again, only the client can say what is safe. And cross-cultural differences, shouldn't be viewed as deficiencies. And trust me, your client will be aware of which perspective you're viewing their culture from. That is a difference or a deficiency. And cultural accommodation really needs to be at the forefront when we're thinking about positive options and positive purpose. So cultural accommodation needs to be accommodated just in the same way that a client's disability may be. So for example, just as you would provide recommendations for diet modification that's based on a client's swallowing difficulties, you should also provide modifications that are grounded in the client's context. So for example, I took a look at a few of these soft diet information sheets that I could find on the internet, and I found that a lot of them are actually grounded in a European Canadian diet. And a lot of these information sheets also make assumptions that clients can afford the plenty of fruits and veggies that they recommend. And so if positive options don't exist for patients who don't follow the European diet or who can't afford the items that are recommended, they won't have the same quality of outcomes as the patients for whom the diet sheets were designed. So just a quick note on cultural safety before we get into the case study. Cultural competence. So cultural competence is a term and a concept that many of us will be familiar with. You might have noticed in the guideline, and as we've been sort of working through these slides, that cultural competence isn't really being promoted as a recommendation as such. Now, cultural competence is a knowledge acquisition system, which involves learning about the traits and practices of different groups in the hopes that this knowledge will lead to the development of skills, behaviors, and attitudes that facilitate effective management of any cross-cultural differences in a therapeutic relationship. And in principle, this is a good place to start, but there are some limitations of the cultural competence model that I want to make you aware of. First, in this assumption that we need to learn about others, this model is really assuming that there's a norm culture, and that in fact others, anybody who identifies outside of this culture. And while being open to learning about others is a really positive step, being presented with facts about the different ways that different groups of people see the world and act can actually result in stereotyping. Because this type of knowledge transfer doesn't allow for variation within groups. So, for example, in a cultural competence training, we might be presented with information like people from X part of the world view the clinician as the expert, and they prefer a therapeutic relationship where they're told what to do, and actually they might feel uncomfortable being asked to collaborate in care. And they might even begin to view the clinician as less competent if the clinician keeps asking them questions because they feel like the clinician should have the knowledge to provide care without collaborating with them. And while all of that may be well and true for people from X part of the world, there may be some people from the same background who prefer to be consulted on their care. And so if we use that information, even with the best intention of being sensitive to the client's cultural needs, we would be applying a stereotype to the client and we wouldn't be providing appropriate care to them. In addition, the language around power and power differentials is typically absent from the cultural competence framework. However, as we discussed, acknowledging power differentials and working to lessen imbalances are key to anti-racist service provision. And lastly, when we have an other client whose differences from the dominant culture we must learn about, it's easy to blame that other's culture when differences in when relationship breakdowns do occur, as we'll see in the case study that we're going to go to next. So in this case study, we have a clinician who works at a community health center. There is a client who's 4 years, 8 months, that comes in with his mother for an assessment. The client is nonverbal, and the clinician observes many red flags for autism. Now, at the end of the assessment session, the clinician discusses their concerns about autism and say that they would like to initiate a referral for a full assessment for autism. Mom reports that she's not concerned about autism and politely declines the referral. So at subsequent sessions, the clinician continues to counsel the mom about the importance of early identification and early intervention for autism, but the mom continues to decline the referral for an assessment for autism, saying that she's not concerned, she just wants her son to be able to speak to her and communicate what he wants. So clinician S then develops a hunch that mom's refusal of the referral might be cultural, the family's South Asian. They consult with a more experienced SLP colleague who's not South Asian, and together they decide that mom might benefit from attending one of the center's play groups for children with suspected ASD, many of whom are of a similar background as the client and his family. So parents in this play group have actually said that the group was an excellent opportunity to build community and support for one another, and that they looked forward to attending every week. So the clinician thinks this is a great idea, asks mom to drop into the group. Mom agrees, but the clinician notes some reluctance. So mom and her son attend the play group, but then they no-show to the next 3 individual sessions with the clinician. So then the family doesn't respond to attempts to contact them, and as per organizational policy, the child's file is closed. So in thinking about this situation, the questions are, how could the provider have practiced cultural humility in this scenario? And what cultural safety considerations could have made for a less harmful outcome? So I'll give you just a couple of seconds just to read it over again and really kind of let it percolate in your mind. And then we'll talk about how cultural humility and cultural safety could have made for a better outcome for this family. So I hope you'll agree that many things went wrong in this case. And just full disclosure, this case study is actually based on true events. It's sort of an amalgamation of different observations and scenarios that I've seen over the years. So when we discuss what went wrong, please keep in mind that what went wrong actually happened to someone, not all to the same person, but it happened to clients accessing SLP services. So when we talk about cultural humility, remember at the core of cultural humility is that reflection, self-awareness of your own beliefs and biases. And as clinicians, we have beliefs and values around disability and values around early identification and labels. And some of that might even be consistent with our personal beliefs. So practicing cultural humility requires reflection on these beliefs. So in this case scenario, the clinician obviously held beliefs and values about the importance of early detection of autism, which is perfectly fine to have those beliefs. But in this case, we have to question how much of their own beliefs influenced what they expected of the mother, and that she should also hold the same beliefs about getting a diagnosis. Something that was also lacking in this scenario was a reflection, an acknowledgement of the power differentials in this relationship. The clinician in this case was making decisions that significantly impact this family. So they were trying to initiate a referral for an autism assessment, which is huge. They also made the decision to close a file at the end. And they also made the decision to potentially expose this family and their family life and their functioning to others within their community. And that is so intrusive. So while the mom kept saying no, the clinician used their power to make decisions on what was best for the family. And they continued to chart a course for their family that the family wasn't on board with because they were approaching things with that expert perspective. And something else to reflect on at this point is really what it means and takes for a caregiver or a client to say no to a clinician who essentially functions as a gatekeeper to their services. So we might like to think that we're approachable, and certainly we're not scary or intimidating as people or as individuals. But just by virtue of being a provider, a clinician, we have a consequential amount of power over clients, and they are aware of it. So think of your own interactions with your healthcare providers and how you feel being in the client or the patient role. So the kinds of situations that happen in the case study are ones that arise when clients aren't empowered to say no or to criticize or to state their needs. Another way that the clinician could have practiced cultural humility would have been by respectfully collaborating with mom. So I hope you noticed that the case study didn't contain any cultural knowledge from the mother's perspective or the family's perspective, because no one asked her for her perspective. We don't actually know, just from the information in that case study, if cross-cultural differences even impacted the situation. However, it was assumed that that was what was happening when things didn't go according to plan. A cultural difference was assumed to be the source of the issue. And we saw the clinician making assumptions that led to a complete breakdown of the relationship. Because just because that group worked for other families, it didn't mean that it would work for this family. So collaborating with mom respectfully could have avoided that issue, and it could have repaired the breakdown when it occurred. So let's also discuss the cultural safety considerations in this case. Like we saw on the last slide, that self-reflection piece is key. Also key is relationship building, and that understanding that for some people, relationship building needs to occur before clinical services can even begin. I know that the way that services are set up for most of us makes that relationship building piece difficult, but it can be a critical aspect if we want to be successful with some of our clients and our families. Relationship building at the start in the case study could have allowed the clinician to gather and act on the right knowledge as they needed to be responsive to the client and to mom. And one thing that the clinician in the case study failed to see in this situation was that the right expertise on how to be responsive wasn't going to come from an SLP. The client could have provided it, or a community organization, or a cultural facilitator or broker. And this line here is the only one that's bolded, italicized, and underlined in this whole presentation for a reason. And that's because clinical knowledge alone will not bridge cross-cultural gaps. And lastly, remember that cultural safety really hinges on the client having positive cultural options, so that care is provided within their norms and values, and that they feel safe in receiving care. Now, in the case study, we saw decisions being made for the family on what was safe and appropriate for them, and that they weren't consulted on these decisions. The clinician should have recognized and acted on the mom communicating and relaying that the services that were being provided didn't feel appropriate to her. So I just also need to mention here that if you are ever in a situation where a client is communicating that something doesn't feel safe to them, verbally or otherwise, it's critical that that's recognized and acted on in a way that doesn't require the client to explain or rationalize why it doesn't feel safe to them. Not only is that re-traumatizing, it could just be very difficult because as a society, we are only just now developing the language around concepts to do with the psychological harm that results from discrimination. So clients may not even be able to process or verbalize what has happened to them. So I know that that might have been a lot of information to process, but I think it's important that before you leave, that you try to set an intention about how you will proceed after today. Think about what you'd like to learn more about, and importantly, think about what you might need to unlearn. And think about if there was anything that struck you as something that you can commit to trying to do differently from now on. The point of asking you to set an intention is really for everyone to see that reading the guideline and coming to a webinar are just starting points. This webinar can't tell you everything you need to know on this topic, so it's important to have a plan for moving forward. That being said, these are my favorite references on the topic, and they were referenced throughout the presentation. I think there are actually 2 reference slides, yes. They are a good starting point, and more information is readily available. I found social media to be especially helpful in my learning, as it includes perspectives from the people who are traditionally excluded from the professional discourse. So this is an area where I'm constantly learning, so I encourage you to keep reading, keep learning, and keep adding to your skills. And we'll have some time for questions now. Of course, if you don't feel comfortable asking a question in a larger group, feel free to email me. So give me a second, I'll stop sharing and start checking the chat. Okay, I'm not seeing any questions in the chat so far. I'm gonna give it 1 more minute, and maybe if no questions come in, then we can finish up a bit early today. So I'm seeing one. Could you name social media accounts that you would suggest to provide additional context regarding cultural considerations? I can, if you'd like to email me about that question, because I'm not sure if I am allowed to give specific accounts, because that might seem that they are ACSLPA vetted. Great, so I will respond by email on that one. Okay, I'm going to put out a last call for questions. I'm not seeing any other ones in the chat. Certainly, and just looking at a comment in the chat around, things to think about in clients where the therapeutic relationship isn't as strong as it could be. And I hope you noticed that I shared a lot of personal examples where I did something or where I was at wasn't where I needed to be. So it is just an ongoing learning process. Don't feel bad if you don't have all the answers right now, just as long as you can commit to setting an intention to learn about more. So how do you ask is another question. How do you ask the question to find out about cultural beliefs, values, and differences? So I think it's just about asking the question in a respectful way. And it can also be, I think it's something that we maybe feel uncomfortable with because we don't want to be, perceived as being judgmental. So I think it's just that piece about bidirectional learning. So maybe you share a bit about how you do things and you can ask the client about how they do it. So it's just you're learning from each other, you're collaborating, you're giving that impression that you want to understand more, and also that you want to share a bit about yourself so that your client can learn more about you. I was just distracted by a couple of the comments in the chat. So really, yeah, it's just about getting comfortable with just explicitly asking those questions. Think about your case histories and the questions you ask. Maybe there's potential to add a question about, what's everyday, what's a normal day for you, like at home. So I think it's just more about, there's not set questions to ask. I think it's just getting comfortable with asking those questions initially. So I'm going to put out another last call for questions. And I think, Mackenzie, you can correct me if I'm wrong in the chat, but I think we will also send out a copy of the presentation, or it will also be available on our webpage. Okay, thanks. Mackenzie is just confirming that the presentation will be available on ACSLPA.ca under the PD section. Okay, so I'm not seeing any other questions. Thank you all for attending. I just also want to thank Mackenzie because they always keep our webinars running really smoothly. So thanks to them. And of course, if you are, if you do want to discuss something more and you don't feel comfortable doing that in the group, you can always email me. Okay, so I think we'll finish up there. And remember, I always have space in my email inbox for any questions that you have. Thank you for attending and for spending your lunch hour with us.